Yeah, hello. Glioblastoma is a very big problem in oncology. And the difficulty with glioblastoma is that the tumor is, on the first place, a very heterogeneous tumor. With several tumor cell clones and a lot of other cells. We also have several genetic abnormalities. And the biggest problem is this tumor changes over time. So your enemy is changing over time. On the other hand, the clinical risk profiles for these patients are also very heterogeneous, and they are here summarized in the RPA classification, so age, Karnofsky Performance Index, extent of resection, and so on. But even within the tumor immune interaction can make distinct subgroups of patients. And finally, the effects of the standard of care radiotherapy and chemotherapy has strongly influences also on the immune system. So that is the reason why it is so difficult to study this disease in trials, the tumor heterogeneity, the heterogeneity in the tumor microenvironment, all the dynamics that goes on, and the heterogeneity of your patient profiles. Unfortunately, that's also the reason why we have not made any progression in the last 15 years for this patient. What do? The glioblastoma gives symptoms and suppresses the immune system. Standard of care is take it out, surgery, neurosurgery. Standard of care was radiotherapy, and we have added between 2000 and 2009 chemotherapy temozolomide. These are the big publications, New England Lancet Oncology. The gain is for half of the patients 28 days. That's the gain. What is the loss? If we give radiotherapy to this highly dynamic tumor, if we give alkylating agents to this highly dynamic tumor, we reduce the immune system and we induce new tumor cell clones that have then the free pathway to death. And that's for 100% of the patients. So the question starts, should we treat such complex tumors only with surgery, radiotherapy, and 1 or 2 alkylating agents? The question is, should we treat such highly dynamic tumor with fixed protocols? It's driving your car without steering wheel here in Brussels. You will crash. So that means we need dynamic combination treatments, and we need at least today to sample real-world data. What could be done? We already can start to add immunogenic cell death immunotherapy with oncolytic viruses and electromagnetic waves, because then we have other mechanisms to kill the cancer. We also are able now to kill glioma cancer stem cells, which are resistant to radiotherapy and chemotherapy. And we can start to change the tumor microenvironment. Afterwards, not during, but afterwards, we have now to build up the immune system to block the free pathway to death. And that we can do with active specific immunotherapy, actively stimulating the immune system against cancer. We start to implement modulatory immunotherapy to facilitate the immune response, and we continue with immunogenic cell death immunotherapy. The tumor does not go into retirement. The tumor will take new initiatives. New subclones will appear, the tumor immune escape mechanism. So we have to expand our immune protection. Besides, we have to treat the tumor microenvironment, neuron glioma axis, hypoxia treatment in the tumor, metabolic reprogramming, a strong anti-inflammatory action, and again, actions against the glioma cancer stem cell. You have to do that with the necessary expertise in neuro-oncology, in medical care, in translational medicine. but you need also the approval to produce advanced therapy medicinal products. Dendritic cells are ATMPs. You need a good manufacturing practice laboratory. You need to take into account your regulations and the legislations. And in Germany, we can use individueller Heilversuch to treat patients. We can do more than only following protocols and guidelines. And as you can see in our center, most of our patients, cumulative treated over the time, are brain tumor cancer patients. Does it work? Well, here are 5 randomized controlled trials contemporary. And in the Linda Liao trial, Linda Liao has taken the control arms of these 5 RCTs as external control arm to evaluate the dendritic cell vaccine. And you see, as I have explained, the RPA classification, the clinical risk profiles. Age is important. Sex, females do better with immunotherapy than males. The Karnofsky Performance Index and the extent of resection. As you can see out of my database, I have taken this criteria to select in the last analysis 90 patients. The profile is completely similar. What is the survival? Here you see the standard of care, the external control arm. In the MGMT promoter methylated patients, radiotherapy, chemotherapy work a little bit better. And in the MGMT promoter unmethylated patients, radiotherapy and chemotherapy work less good. And as you can see, with the vaccine, here there was no difference at all. Here there was a significant difference. With the tumor treating fields, which is in fact a form of immunogenic cell death, the Stupp randomized control trial published in 2017, it was a significant improvement in the MGMT promoter methylated patients, but also in the MGMT promoter unmethylated patients. We have real-world data, and here are our survival curves. If you summarize the statistics, the median overall survival, a real jump in the good direction. The percentage 2-year overall survival, almost a doubling in the overall survival. In the MGMT promoter methylated patients, again, a real shift in the overall survival and almost a doubling in the percentage overall survival after 2 years. We, however, have to say, observed is not evidenced. It's not controlled. But if you see this, then it might give an impression that the treatment works. We have published this case last year because we also saw lower in the brain at the other side changes which were immune mediated. So in conclusion, we think that we should change the treatment for glioblastoma, not only neurosurgery, radiotherapy and chemotherapy. We can consider targeted therapies, targeted immunotherapies, antibodies, conjugates, CAR T cells. We certainly have to consider immunogenic cell death mechanisms, biological treatment, oncolytic viruses, physical treatments, tumor treating fields, Optune. That's a first layer where we can directly break the cancer down and we can already start the immunization. But it's not enough. We need a layer on top of that with active specific immunotherapy. Nobel Prize Ralph Steinman. With modulatory immunotherapy. Nobel Prize Alison Honyo. They give not the Nobel Prize for nothing. They give it because we have to use it in the appropriate way. And then finally, we have to maintain the treatment because of the cancer dynamics. And we have to include strong tumor microenvironment treatment as well. And we have to deliver to the community real-world data, which should then be, at the moment, also accepted by the community. I thank you.
Thank you very much. That was fascinating. Thank you very much, Stefan. Next, I'd like to welcome Rebecca Lobu, Chief Executive of the Insidium Foundation. Rebecca will walk us through their public-private seed grants that are catalyzing early-stage, high-risk research projects, showing how targeted philanthropic investment can seed breakthroughs and de-risk them for larger funders. Rebecca, the stage is yours.
Good afternoon, ladies and gentlemen. I'm Rebecca, representing the Oncidium Foundation, which is striving to enhance access to radioligand therapy to everyone, everywhere. So radioligand therapy is also known under radiotheranostics or targeted radionuclide therapy. So could you please raise your hand if you are familiar with this type of technology? You do? Thank you. Okay. So, in a few words, for those who are not very familiar, how does it work, radioligand therapy? It's based on molecular pairs. So basically, it's a ligand that will bind onto the proteins that are on the surface of the tumor cells. So if you can reach the tumor cells, we will first attach imaging compound to it, so we can detect it. So we used to say, see what you treat and treat what you see. And if the images is efficient, we will then move to a second phase, which will use the same ligand, but we will attach a therapeutical compound that will destroy these tumor cells without affecting the surrounding tissues. So it's really an effective targeted cancer therapy. This therapy is used a lot for prostate cancer, neuroendocrine tumor. It's even reimbursed in some countries, but it also shows efficiency in other applications. And here is an example of a 16-year-old neuroblastoma patient. So, the Oncidium Foundation is a non-profit organization, totally independent from any pharmaceutical or commercial company. And we focus on enhancing access to patients. And we organize our activities around three pillars that are access, education, and hope. And here it's a whole virtuous circle that we try to create. If we have more education, it will lead to more access. More access will lead to more hope, and so on. So it's very important. So keep in mind those three pillars. And in terms of access, so last year, 2024, 25,000 patients have been treated with radioligand therapy. It's not a lot, but it's expectation. We expect that this figure will double this year. But do you know how many patients have been treated in low-income countries with radioligand therapy? 0. That's what we are fighting for. But I don't want to. I would like to leave Fernando, a prostate cancer patient living in Buenos Aires. Tell us his story.
Y 5 días de sesiones continúan con un plan quimioterápico, llegando así a 42 sesiones de quimioterapia. Yo no sabía qué más hacer. Mi oncólogo me cuenta la posibilidad de hacer un tratamiento con lutecio y averiguo, la obra social no cubría este tratamiento y tras esto logré que la Fundación Oncidium se comunicara conmigo y me diera cuenta de que sí o sí yo iba a recibir este tratamiento nuevo.
I'm removing the chair so you can read the caption. So to enhance access to this patient, what do? We have developed a network of ambassadors. So these are experts in radioligand therapy in more than 60 countries. They make our global mission a local reality. They know the barrier they are facing in every country, and really they work striving to enhance access to radioligand therapy in their countries. And it is through this network of ambassadors that we have been able to help Fernando that you have seen. Do you remember what's our second pillar? Education. Thank you. Education is key. Why? I told you, radioligand therapy is at its early stages. So it really needs education and raising awareness around this. Let's let Jean-Antoine from Egypt tell us his story and how he came across this type of therapy through our educational content online.
And I started to look for treatment, and I went to the oncologist. And then I started to look on the internet, and this is where I came across Lutetia. I took my first shot on the 2nd of September 24, which is today a month ago. It went just beautiful, and beautiful is the least I can say.
So now Jean-Antoine is doing very well. He received this treatment. Despite all other treatment, did not work for him. And he came across to this educational content online, and I told you education is really key. So we have a whole team working on raising awareness and create targeted educational content for patients, patients associations, for the healthcare professionals, as we are doing today in such a conference, but also for the nuclear medicine community, where we provide high-level, independent, and neutral content. And our third pillar is hope. And I would like to let Malena, the young lady who you have seen the picture at the beginning with a neuroblastoma, telling us part of her story.
El entorno médico y el entorno familiar siempre van a estar ahí y no importa de qué humor estés, todos te van a tolerar y todos lo van a entender, y que esto no es todo, hay mucho más, y que siempre hay fundaciones como Oncidium que te pueden ayudar a llegar a más tratamientos.
So the third pillar is, for me, the most important of the Oncidium Foundation is hope. And in this department, we have created a program, a treatment donation program for underprivileged patients in countries where there is no reimbursement. So basically, how does it work? It's an online platform where the physician, they submit the case of their patients. And on the other hand, we have agreement with radiopharmaceuticals company who are donating doses for these patients. So it's like an offer and demand, and we are creating matches on this platform to make sure these patients can be treated. So in 1 year, we could have nowadays approximately 150 doses administered, and this program is running in more than 16 countries. And this is one of the things I'm most proud of in the achievement of the Oncidium Foundation. Our aim is that in 5 years, we have 2,000 doses donated for the patient who cannot access this treatment otherwise. So that's it. I thank you for your attention. If you are interested to know more about the foundation, follow us on social media or meet us at the post. Thank you very much.
Great. Thank you very much, Rebecca. Finally, please welcome Andrea Caputo-Svensson, Global Health Advisor at REACT Europe. Andrea will present REACT's latest multi-country pilot on community-driven antibiotic stewardship in oncology settings. Andrea, the floor is yours.
Yeah, thank you. Thanks so much. And I'll start with the video, if it's possible, and then I'll do some remarks afterwards.
Millions of people around the world die every year because they're unable to access effective and affordable antibiotics. REACT is putting equity at the centre of action against antibiotic resistance. The global network prioritises solutions and political change towards ensuring that all have access today and tomorrow, no matter where they live.
In the heart of Zambia's capital city of Lusaka lies the Matero community. Matero is a densely populated neighborhood where access to basic amenities like water and sanitation is limited. Here, due to challenges of accessing clean drinking water, vaccines and poor sanitation, diseases like respiratory and diarrheal infections are common. This increases the use and misuse of antibiotics in the community and drives the emergency of resistance to commonly used antibiotics, thereby making it difficult to treat these infections. Mavis is part of a group of local leaders working with the global network REACT to teach communities how to prevent infections, which are often a result of poor hygiene practices and knowing what to do when you get sick.
Sometimes you can get sick, you go to the hospital, and you stand in a long queue, only to be examined by the doctor and given Panadol. Then you're also given a prescription to go and buy. Because of lack of finances, maybe you can get just a half or quarter of the antibiotics.
Mavis and her team belong to the United Church of Zambia and also use music to encourage participation in their hygiene programs.
There are places where you find that they have built a lot of houses at the same place, but one pit latrine. So we've mounted the tip taps. We tell them each time when they're using the toilets, they should wash with clean water and hand wash.
REACT is advocating for the proper use of antibiotics to avoid misuse and overuse of antibiotics in both humans and animals. The inappropriate use of antibiotics is a driver of antibiotic resistance, especially in community settings. REACT is making a difference in communities by creating awareness about antibiotic resistance. Communities are advised to seek medication from proper healthcare professionals rather than over the counter. Doctors also warn that antibiotic resistance poses serious health risks for patients and that timely access to effective treatment is crucial.
So I've seen a number of patients that come into the facility with a suspected bacterial infection that is maybe causing diarrhea and fever, which could be typhoid or any other enteric disease. So we found that some of these patients are not responding to the first-line antibiotic treatments that are available and might need to be referred to a higher level facility. So this usually causes a delay in them receiving the effective antibiotics that will actually treat the infection and can end up causing avoidable deaths or complications.
While REACT is also advocating for access to affordable antibiotics, regardless of social status, the network is calling for stricter regulation of the use of these medicines to increase appropriate use of these life-saving medicines.
We actually are a strong voice advocating for ensuring that there is access to antibiotics for everyone who needs them, because that's what our mission actually stands for, that we would want to see sustainable access of antibiotics to everyone, regardless of geographical location or economic status.
REACT is now advocating for functional diagnostic labs so that health workers are able to determine if antibiotics are needed and which antibiotic to prescribe.
It's important that antibiotic resistance actually is tabled as on the global health agenda as we would want to see it. If you look at low and middle income countries, you'll notice that we face a number of challenges, right from the weak healthcare infrastructure. The challenge is water and sanitation also further aggravate the problem, where the highest burden of infectious diseases are.
While Mavis and her team say they won't tire of spreading the word about good hygiene practices to prevent disease outbreaks in their community, REACT advocates for increasing antibiotic production within the African region to improve patient access. And REACT's mission is to enable collective action so that people in the Matero community, as well as everyone else, have timely, affordable access to life-saving antibiotics. This is part of everyone's right to health.
Thank you. Thanks. Yeah, I wanted you to see the video. First of all, I need to, of course, mention that the video was done last year together with ITN for the high-level meeting on AMR. So it was specifically directed to antibiotic resistance, but I thought it was important to also show it here because as we discussed in the previous session this morning, infections are the second leading cause of death for cancer patients. So it's important that we preserve the antibiotics that we have and that we discuss about access. Something also that when it comes to innovation is not as perhaps innovative as we heard from the previous talk in terms of technology, but I think what's important here, or the key message that I want you to go home with is that really empowering communities. We heard before from some of the patient speakers, excellent story about how to give voices to patients and to communities, and that's what we're trying to do all over the world. You saw now the Matero community, but we also work in Latin America. We have our offices in Ecuador, so we work very much in that area as well, but also in Asia Pacific, we have our offices in India as well. Something also that I wanted to mention here that was highlighted when it comes to antibiotics, but definitely also connects to cancer care, it's affordability. As you heard also this morning, there were some talks about how certain therapies are cheaper than others or not that expensive, but it's always like according to which standard, not that expensive. Because people here, as you heard, but also from other studies, we know that, for example, to undergo breast cancer surgery and the entire treatment can cost up to 10 years of an average wage for Indian or South African. So we do understand that this is extremely scary, and for the people that can afford it because they've been saving money, they then are pushed into poverty. So it's not really solving one issue, but it then causing something else. One of the initiatives that we did last year, also in connection with the high-level meeting on AMR, was it's called From People to Leaders, and it was an initiative done in conjunction with different communities all around the world. There was a consultation process before, there was a discussion in how do we make sure that we hear what communities and what the patients say, and that's how we did it. So through a consultation process, we came together with a call for action, and the call for action over 3-4 months collected more than 800 signatures. I think this is like an important number because from the outset, when we discuss about antibiotic resistance, always it's hard to understand what type of community we're trying to involve because it's not a disease per se, as it can be cancer, as it can be HIV or TB. But the fact that we managed to collect 800 signatures, but from individuals and civil society organizations and communities, including cancer patients and cancer communities, it's a really signal that whenever there is a right cause, it's important that there is someone that can provide a type of platform. And that's what at React we're trying to do, providing a platform that can connect both what are the community needs, what the community voices are saying, and showing those to the policymakers. So what we did, the last step, was indeed to hand over the call for action to the policymakers during the UN High-Level Meeting Assembly. And you can read within the declaration that was the outcome of the high-level meeting that some of the language that we also adopted in our call for action was somewhat reflected in the declaration. So that's, I think, a proof of strong advocacy and how we can all come together towards the same cause. And I just want to conclude with our motto or our mission, which is a world free from untreatable infections. And I hope that everyone else in this room can join us with that. Thank you.
Thank you. Thank you. Let's give one more round of applause to Stefan, Rebecca, and Andrea for these thought-provoking presentations. Thank you.